Good morning. I don't want to knock this off again. Let me untangle. Thanks for the introduction, Bob. I'm very pleased to be here, for inviting me to come down. And this is the long version of the talk that I have to give in 2 slides at the theme discussion talk at Croy next week. So you don't have to ask any questions because you'll know all the long details. So as Bob said, I've been interested in adherence and been working with antiretrovirals and people living with HIV for quite a long time. What I want to talk to you today is one of the papers that has come out of my PhD, which I did late because I had children first, did PhD later, which is the wrong way around, by the way. And this is the second of 3 papers that have come from my PhD. So I want to explain sort of how I came to be asking this question and then what the results were. I'll briefly mention the outcome of the main study, but mostly talk about this adherence comparison piece. So, as many of you know, because I know quite a few people are doing work in South Africa, sub-Saharan Africa, antiretroviral options are actually very limited. There's only very few options available to us in the public sector. There are over 6 million people in South Africa who are HIV positive. Currently, we're treating about 3 million of them, but as the guidelines change, we're going to be treating closer to this 5 or 6 million as we start to treat earlier and potentially test and treat in the end. And first line is currently tenofovir, M.Ch.B and efficacy, 1 tablet a day, about 95 Rand a month, which I would have said was $9, but is now, as the Rand is sinking rapidly, it's probably only about $6 a month, which is very little, and relatively cheap. Not if you're treating 3 million people a month, but you know, still relatively cheap as far as treatment goes. Second line, however, becomes a lot more complicated. At the moment, our options are Combiviz, Zidovudine, Lamivudine, and Eluvia. It's currently around about 300 Rand, just over a month, which means it's like 2.5 times more expensive than first line. So really, we need to maintain people on first line in terms of our program, in terms of programmatic success. We can't afford to have 6 million people on second line. We need them to be on first line. It's easier to take. It's easier for drug distribution. When you're thinking of dispensing drug to rural clinics in the middle of nowhere, it's much easier to be giving 1 bottle to all these people than it is to be doing 3. So practically, it's easier, it works, it's an efficacious regimen, it's safer, and it's cheaper. So ideally, we need to keep people on first line. However, adherence is not so easy. I've left out the initiation piece here. I'm not even going to talk about linkage to care. My work starts when people actually come to a clinic and start to take medication. I know there's a whole realm of research that happens prior to that point. But from when I start talking about research, about adherence, we're basically talking about implementation, which is taking the tablets every day at the correct time, and then persistence to care, and not discontinuing care. So basically trying to ensure there's no treatment interruptions and that we retain people in care. So there's a number of different components. They're going to impact on different people at different times in their lives and things like that. But basically, it's important to get right. So there are consequences to not taking your medication correctly, and that is that you'd fail and you'd end up on second line. And just to explain briefly, this is my pharmacology piece coming out, that when you take a single tablet of the A-tripler or the combination regimen, the drugs actually have differing half-lives. And 3TC or the FTC component will come out before 24 hours, tenofovir a little bit longer, and then efficacy has quite a long half-life. So if you take your medication at 24 hours, you don't have really any period of monotherapy. But if people skip doses, and by the time they miss their 3rd dose, they have actually got a substantial period of efficacy monotherapy. And unfortunately, the virus is not very forgiving. It doesn't say, oh, you've had a bad day. I won't replicate in your efficacy monotherapy piece. It still actually replicates, and a lot of people get resistance. And you can get resistance quite quickly from missing just a couple of doses of your first-line treatment regimen. So although the first-line treatment regimen is brilliant in many ways, it's not forgiving. So we have to try and get people to be taking their medication every day. So avoiding treatment interruptions is one thing. And so trying to keep people on the straight and narrow. And these are people who are poor, who've got lots of complexities in their lives. There's a lot of alcohol issues in our community. And things come in the way of taking your treatment every day. So effectively, when you look at overall adherence, and I borrowed this slide from Jean Nesega, is the better you are at your adherence and you get complete viral suppression, you shouldn't really get any resistance at this point. But you're talking at people here with adherence in the 90 to 100% range. If you're down here, quite often you see wild-type virus, and there's either inadequate pressure to select resistant virus, or you don't see resistant virus because their wild-type virus is able to grow quite happily because there's not enough drug to suppress it. Most of my patients sit with an adherence nicely in this range, kind of between 75 and 90%. So which means they're doing really well. And I'm always honest with my patients because I have never completed malaria prophylaxis. I don't think I've taken 15 amoxicillins in a row. So I can't tell them, to do better than 75, 80%. You can encourage them, but 75 to 80%, there's a really interesting study a colleague of mine did in TB, just a small, I don't think she ever published it, she's not an academic. But basically, people who had completed their TB treatment and had taken 80% of their tablets were convinced they'd taken every single dose. They knew they'd taken 80%, but they were convinced they'd taken it. So when you're taking 80%, you're doing really well. And for TB, you'd be considered cured if you'd taken 80%. But for us with HIV, that's not actually good enough. So we've got to take what most people do, which is this, and try and push everybody up to perfect. And in resource-poor areas, we'd actually done very well. This was my first entry into adherence, and I was incensed by Andrew Natsios's. He made I've forgotten the exact words now because it was a while ago, but he basically said Africans couldn't tell the time and therefore they weren't going to be able to take the medication. That got right up my nose. I was really quite cross. So I went and I had a look. We'd been doing antiretroviral treatment trials for quite a while then, so I went and had a look at our treatment trials and found that we actually had an adherence of about 93.5%, and I published that together with David Bangsberg in AIDS 2003. And this is one of the things that has actually worked towards changing policy. Because I got cross with Andrew Natsios, we found out that people could actually take the medication in Africa, and that also helped to reduce the barriers for people to come forward to try and to offer money, like the Global Fund came first to try and access treatment for people in sub-Saharan Africa. And since then, there have been multiple African studies that have shown excellent adherence from all over the various parts of sub-Saharan Africa. And in our cohort that I've worked in since 2002 in Guguletu, 94% of adults had adherence over 90% in 2001. So all in all, people do generally quite well. However, so there's still a yet, or however, the numbers and rates of people who are failing antiretroviral therapy is still increasing. And you imagine the scale of the program, even if only 2 to 3% of people fail a year, that's still going to be a lot of people over a longer period of time. And in fact, the rate looks on average to be more like 5 to 6% per annum failing first line, which is now substantial numbers of people that are failing first line. So in Guguletu, we saw 5.6% at 3 years, but this was quite a while ago already where we had smaller numbers on our program. Now we're looking more at 6.5% at year 1 in our same program. Anthony Harris from Malawi noted 15 to 25% detectable viral loads by 12 months. And a Joburg team with Matthew Fox noted at 16 months, 9.9% first-line failure at 16 months. So the original, all this lovely data on good adherence is all very well. But basically, we are still having a substantial amount of failure, which is significantly important for programmatic reasons. So just looking at the Guguletu cohort where I worked, and this is using tablet returns as a basis of adherence, I had a look at what was actually happening in terms of viral suppression and adherence outcomes. So when you look at adherence as over 95% by tablet counts and viral load suppression as being under 50, only 60% of the cohort have both viral load suppression and a good adherence. Then there's people who fail, and they fail with poor adherence. That's only about 7%. If you actually look at the people in between, there are 19%, which is quite a lot of people who have good adherence on tablet counts and viral loads, so they look like they should suppress on adherence, but they don't. So I call those the people with unexpected non-suppression. So they have adhered according to our measure, but they have failed virologically. That's one group of 19%. And then over here we have the people whose adherence has been poor, but have actually suppressed. and about 13% of people have suppressed their viral load, even though their adherence has been poor, according to our measures. So knowing that we're trying to get everybody to adhere and that we're trying to stop people from failing, this is quite interesting because only 67% of the cohort is doing what you expect them to do. So that means you've got 33% of people that are not doing what you expect them to do, and some it's good and some it's bad, but it's still not what you expect. So for me, we need to know, we need to narrow this window. We need to know what people are doing. People need to do what we expect. So my questions were, why have we got this? And why have we got this? And that basically led to the question that I posed for my PhD. And the first one was, perhaps we aren't measuring adherence very well. And if you actually go and you look at the adherence literature, you find we don't measure adherence very well. And this is one of the key factors for the whole treatment outcome, and we actually don't yet know how to measure it. And for me, I find that astonishing. However, now having worked on it for 3 years, I still don't know how to measure it really, but I'll tell you a bit more about that in a minute. So we know that subjective adherence is the least sensitive. Most people, and I know I'm speaking in a psychiatric institute, so I'm talking as a researcher where you ask somebody, did you take your tablets? Not motivational interviewing, cognitive behavioral therapy, where you're more likely to get a reasonable answer. But if you ask somebody, if my counselors ask somebody at the clinic, in the last 3 days, did you miss a dose? Most people say no. They say, yes, I took my tablets every day for the last 3 days. So for me, that kind of self-reporting is not very sensitive. And in reality, that's the kind of self-reporting that gets done at our clinic. There isn't time to spend much more effort, expending much more effort. And this is not being asked by the doctor. This is being asked by a peer counsellor, usually somebody they've known since they started their treatment. So that's that. Tablet counts we've done at our clinic all the time. We know that also overestimates adherence. We know that people can actually fiddle their tablet counts. They think, oh my gosh, I'm going back to the clinic, shake their bottle, there's about 6 in here, let me take out a few. I know I have to bring back some, but not all of them, and they can take out a few. And not many people admit to that, but we kind of assume it's happening because tablet counts generally overestimate adherence. Pharmacy refill data I've not put into my little circles here, but pharmacy refill is also probably overestimates adherence a little bit in this sense. We don't know what actual adherence is, and I'm not sure how we're going to measure it ever, actual adherence. And then there's electronic measured adherence, which might underestimate adherence a bit. But this is my schematic, I'm just guessing. So what I decided to do was measure all of these in one cohort and follow them prospectively and see which one in one cohort actually had a decent, which one actually came out the best. The other half, which I'll get to in a minute, the other piece of which I'll just go back a slide so that I don't lose you altogether, but this bit over here, and unexpected viral suppression, might be due to efaviren's pharmacokinetics. And I'm not going to go into details of that, but I've got a slide further on that basically in sub-Saharan Africa, about 20%, between 15 and 20% of people have different cytochrome genetic genotype for efaviren's metabolism for 2B6, and they have higher levels of efaviren's than the average. So it might be that in some people who are not taking their medication, the levels of drug remain in the blood for a bit longer, and it's slightly more forgiving than average, and maybe these people this subset of people is achieving viral suppression without actually having to take every single dose. So that was my theory, and I put it all together in a question in one study, which I'll describe to you in a moment. So my interest came in, so having looked at all these different methods, in Google we'd be doing this already. We had pharmacy refill data, which we hadn't looked at. What we didn't have was electronic adherence. So I'd been involved in some guideline writing, which Bob had mentioned, and basically people were singing the praises in 2012 of electronic adherence reminder devices and SMSs. 2 studies had just come out from Leicester and Populations, which basically showed how reminding people or sending people SMSs really improved adherence. And so I decided I would include electronic devices in my study as well. Since then, there have been 12 randomized studies from resource-limited settings, of which 7 have shown adherence benefit, and 3 of these 7 have also shown biological benefit. However, 5% have shown no adherence or biological benefit, so as time has gone on, We were very enthusiastic at the beginning, but there are some subtleties to using technology, and it may be more suitable in some populations and not in others, and things like that as we go on. I'm going to skip through these slides, but I'm going to leave the slides with you. So these are the 12 studies that basically show that basically have been used SMS or reminder technology to improve adherence. And the green ones, you can see there's 2 over here. So for me, the biological outcome is most important. We actually it doesn't matter if adherence improves if there's no biological outcome. So 3 out of 12 having biological outcome is actually a bit disappointing. So there was the original study, which caused all the excitement, by Rich Lester, where there was a decrease in RNA. There was an unpublished study from Guatemala that also showed a decrease in HIV-1 RNA. And there was a study from Maduka from Nigeria with an increase in CD4 count. And of those 12 studies, there were basically only 3 with biological improvement. So that's the second slide to say why. That was just to say the pharmacokinetic piece, the other half that I explained. So the unexpected suppression might be due to pharmacokinetics, but I'm not going to discuss that here. There is a poster at Croy if you have a burning need to go and check out that bit. Right, so I developed a study that I call the TAP study, which is a randomized trial to explore adherence failure relationships using an electronic adherence device and pharmacokinetics sampling. So I had data on adherence, lots of data on adherence. I collected every version I could think of monitoring adherence, and that's what I'll show you today. We had the WISE pill devices for technology. I did both genotypes of 2B6 and HIV genotypes and drug levels in one cohort over a year. So my objective was to explore all these different questions in one cohort. My primary outcome was published last year. Does a reminder if dosing is late improve adherence? And the answer was no, which was very disappointing, to be honest. Basically, it all went the right direction, but not with any significance. What it did do, the reminder, so basically what I did was people had this WISE pill device, and if they did not take their dose on the time they told us, 30 minutes after the time they told us, we sent them an SMS reminder. Half of the people got reminders, half didn't. What that did was adherence did not improve, which showed me that it's not forgetfulness that makes people not take their tablets, because if I got an SMS and I'd forgotten to take my tablet, I'd probably go, oops, and I'd take it. And people didn't do that. So a reminder did not improve it. But what it did do is it reduced treatment interruptions. So I said a treatment interruption of 3 days is important because of the monotherapy piece for efavirenz, and that those reminders reduced the number of treatment interruptions of 3 days or more, which was quite interesting. And I don't know how to explain it. I've called it the nag effect. Like if you start getting a text every day, eventually you take a tablet to just shut Dr. Orrell up, you know. And so basically the numbers of treatment interruptions were reduced in the people on treatment, but it didn't change the overall adherence, which means it's a change in pattern. And I'm still working with some people who are cleverer at me at that analysis to actually put all the dosing times, because we've actually got dosing times for 230 patients over 365 days. So it's very detailed, very rich data, but it requires a really good statistical brain to actually work all that kind of stuff, and we're still working on analyses of actual dose and timing and drug levels to try and see how the patterning, actually, to work on that patterning to see how that works. So what I'm going to present today is which adherence measure best predicted virological and resistance outcome in that talk. So this was a group of HIV positive individuals. They came to us just as they started therapy. That's the WISE pill device. That recorded daily adherence electronically. It has a SIM card in it, sent it off to a server at Somerset West. I know Bob's got a lot of experience with these. So it connects to the mobile phone network, and you basically get real-time monitoring of opening. This is a typical outcome of this is somebody obviously on AZT or nevirapine, because they've got twice a day dosing at 9 in the morning and 9 at night. And we put reports in the folders of people on the intervention arm. These reports got put into the clinician's folder as well. So the clinician had some input into and this really, I mean, as part of the intervention was an SMS and putting this in the clinician's folder, and it didn't make any difference at all, which is quite upsetting, because I mean, for me as a clinician, this is important, particularly when your patient does this. This is January 2013, and this is February, and this is March. So she didn't do very well over time. It's very, very hard not to intervene as a clinician who's interested in adherence when you see these things. And so it was one of the things I discovered we were putting these in the folders, but people were not acting on the stuff that we were actually giving them. So we also collected record-based, clinic-based pill counts, which for week 16 was 30 days. At week 48 was a 60-day, basically asking tablet return. So at week 16, they'd have been given 1 month of medication prior to that. At week 48, they'd be getting it every 2 months. 3-day recall, self-report, which is also in the folders. And pharmacy refill, 2 different pharmacy refill measures. One was cumulative, which basically looked at the number of tablets they were given over the time to week 16 and 48, and the number of days there were between week 16 and 48, and a simple fraction. You're given 360 tablets over 365 days. And then a slightly more clever one, which basically looked at gaps. So that required us to look at the dates of each dispensing, and even if they'd been given 360 tablets, there might have been a gap, saying if they were given 30 tablets on the 1st of March and they only collected the next one on the 4th of April, there would have been a 5-day gap when they could not have had tablets. So even though it might look fine overall, you could actually pick up the gaps and have a look and see, and that had been shown in another analysis to be quite sensitive as well, to actually look at the tablet-free days that people had. I took blood for a mid-dose efavirenz level, and we had the dose based on both self-report, and we had the dose based on the Wise Pill device, when it actually told us when they took the tablets.
What do you mean by mid-dose?
So when you take efavirenz, you take it at 9 o'clock at night, and most clinics aren't open for trough samples at 8 p.m. So we take them the following morning, which would be like 9 or 10 a.m., and so that's mid-dose. So it's between, and it's standard, because the efavirenz is dosed at night, it's kind of standard pharmacological PK stuff is you take a mid-dose rather than a trough. For a lot of drugs, you take trough levels to see how low the drug goes before you take the next dose, and that's been very hard to do with efavirenz, so we kind of make do with these mid-dose levels. Once you're in steady state with efavirenz, your drug levels basically are quite flat if you've been taking it well, so mid-dose and trough are very similar because it's got such a long half-life after a while. I stored blood. I took viral loads at week 16 and 48 and stored bloods for HIV genotype at that stage as well. I also took hair. I'm still waiting for that analysis because you basically lay your drugs down in hair. So it'll be interesting to see how that comes. I had to take 40 hairs at least from a person, which was a very interesting process. My study coordinator didn't like it at all. Firstly, men don't shave their heads. Most of men shave their heads, so we had to make a decision that we weren't going to go for anywhere else. We'd only go for head hair. We weren't going to go and stop. Anyway, and a lot of women have braids, and they don't want you to take a whole braid or a piece of a braid. So sampling hair, it sounds easy, but in fact, I probably only got 60% of people to give me hair, and most of them are women, because the men didn't have any hair. And then the only way I got funds for this was through an ACTG NEDA grant. So now I've had the pharmacology people are having to do methamphetamine, cocaine, opiates, and cannabis levels on my single 40 strands, which were only for efavirenz. So I've now stretched their capacity. So anyway, but those results should be out quite soon, because I'm looking forward to that, to see how that fits in. But again, I can't show you that here either. So then basically I looked at each of those adherence methods, and I did univariate and multivariate logistic regression models for each measured relationship to both virological failure and resistance at week 16 and 48. And then I used the receiver operated curves view of overall predictive power of univariate and multivariate models. So each adherence measure was in a different model. So on its own with outcome. I'll show you that now. And the area under the curve derived from that rock with 95% confidence intervals was used to compare the predictive value. So now the next 4 slides are a bit boring because they're all the same. Oh no, they're not. It's not the next 4. Hang on. Do this first. So basically, for the study, I screened 319 people. I got 230 people on the study, and they were in different, both in 115 in control and 115 intervention. For the purpose of this study, I've combined them all together. As there was no difference in adherence, I feel justified in combining them all together to look at adherence, because there wasn't a difference in this study. The cohort, in terms of outcomes, was pretty similar to any other cohort in South Africa. We had about well, about 3% of people died, which is good. It used to be a whole lot higher than that. We had about 8% of people lost to follow-up at a year. which is also reasonable for that cohort. It's not great, but it is kind of what happens in a year. And we had quite a lot of people transferred out. About 7 or 8% of people transferred to care elsewhere, who we count as still in care. I might not know where they are or be able to follow them, but we count them as still in care for those. So it was a pretty typical cohort in that sense. And also typical in that it was 65% of the cohort were women, which is also what we see in sub-Saharan Africa. Average age at treatment start was 34 years. Average height, average weight, high body mass index, as is the way as well. And what's nice for me, having worked in this cohort for quite a long time, there were many fewer people with stage 3 and 4 WHO criteria than in my previous studies. It seems that the cohort is actually getting more well over time, which is quite good. And the first analysis I did on this cohort, our starting CD4 count was 84. And it's come up through 100 and something, and now in 2013 it's 225. Now at that stage we'd already been including people with CD4s at 350 for quite a long period of time, so we're not close to 350 yet, and now we're on 500, so we're always lagging, but it's still a heck of a lot better than it was in the last decade. Viral loads, 4.9 log, so quite high viral loads at baseline. Everybody is on an NNRTI at start. Most people on Adherence, and most people on tenofovir. And if you look at I used a HADS depression score, and again I'll probably get slayed here, but that was the one I was told was was a good way of basically determine if someone needed referral. It's not going to diagnose for you, but it's basically going to pick up somebody you would refer then to the psychiatric nurse or the psychiatric registrar who came through to Googlete you, and it was easy to be done by our counselling team. And we found that we referred everybody with a score of 8 or above, and we found 32% of our cohort had a score needed referral for depression, and 38% of our cohort needed referral for anxiety, which is quite high. Only 4% had non-disclosure, which means they'd not told anybody at all. That was lower than I anticipated, but it's still a chunk of people. And 15% had serious issues with alcohol based on the CAGE score. So there are many issues in this cohort which an SMS would not obviously deal with, which is, anyway, but there we go.
Overlapping so that some people had multiple.
Some people would have had multiple diagnoses, yeah. And these are the median adherence reports at week 16 and week 48. So this is self-report. Remember, I just basically asked, this is the median, this is the interquartile range. So at week 16 and week 48, everyone was perfectly adherent by self-report. By pill count, it's very similar, but at least we get a bit of a range. You see, so people on average by pill count get it right, but some people, there is a bit of a range. Pharmacy refill, early on, pharmacy refill, people get 30 tablets, and often they come back on 28 days. So you do get if you're using pharmacy refill, you get an overestimation of adherence because, they come back and you've got more tablets than anticipated because your weeks have 7 days in them, but your bottles have 30. So you tend to get a little bit over, but again, there's quite a bit more range, particularly when you get to week 48. When I looked at gaps at week 16, that was, again, very much the same, and at week 48, 100 with 95 to 100%. So so basically, all those adherence measures that we had been using up to now gave you very good, overestimated, probably, adherences. The electronic adherence from the WisePill device, this has stopped. Basically gave 93% at week 16 with a range of 74 to 98. So maybe underestimated, but maybe more realistic. We'll have to have a look. And at week 48, the EAMD adherence was 86% with an average 59 to 94%. So when I looked at my Adherence concentrations, they were nicely where they should be at both arms. And again, when you take a drug level, you're going to get a reasonable drug level if you've dosed the day before your visit. So it's not necessarily going to be, it can also be overestimated. And at week 16, 93% were virologically suppressed, and at week 48, 85% were virologically suppressed. I think I've killed the batteries on the remote. Waving the pointer. Just use the arrow keys? Yeah. Okay. So now this is where I really need the pointer, but I might have to get up and point for you. So this is now, basically, these are the 4 slides that look the same. So this is looking at each adherence measure at week. Now I'm not going to be able to move because of this. Hang on, I'll work this out. Take this with me because I can show you which one's significant and which ones are not. So this is looking, and they'll be in the same order for each of these slides. So this is looking, the outcome here is virological failure. The week is week 16. This is the WISE pill. And you see there's quite a nice curve there. So I don't know how many of you know, I mean, I'm sure a lot of people do, about ROC curves. When it does this, it means there's no significance at all. This is self-report. Okay. So, yeah, anyway, there we go. This is the WISE pill device. This actually was not significant. What were significant were the 2 pharmacy refill measures at week 16, which is quite interesting because we have pharmacy refill available to us. And at week 16, it was the only ones that actually showed impact on virological outcomes. This one with a 75% area under the curve is the average, and this is gaps. So that was the other thing that was interesting to me. The average and the gaps came out much the same, even though you'd expect the gaps. Okay, thank you. Even though you'd expect the gaps to be more specific. So that's failure. This next one is looking at resistance. And so this is week 16 again, looking at resistance as an outcome. So resistance was any single mutation, major mutation according to the IAS 2015 guidelines. So they had to have an M184V mutation or K65R or something like that to show resistance. And any one mutation, they were then resistant compared to the other one. And again, this is the WISE pill. Pharmacy refill 2, this is the gaps, this is average, tablet returns, drug concentration, and self-report. We all get a little giggle at self-report. But basically, none of those were significant in terms of resistance. So none of the adherence outcomes actually predicted resistance at week 16, which is quite interesting. So then going on to the week 48 data, in this setting, the WISE pill, both pharmacy refill and the tablet returns were actually significantly predicted outcomes. The WISE pill and the pharmacy refill data did it the best. So the bigger curve you can see, the better. But there wasn't actually any significant difference between the predictive value of the WISE pill device and the pharmacy refill. And tablet returns, which is nice for me because I've been making counsellors count tablets for about 15 years, did actually show some predictive value. Again, it's not as good as the others, but it was better than nothing. Drug level and self-report basically did nothing. This is just a straight looking at a spot efference concentration at that visit. So no adjusting. So in the second PK paper, we adjusted to look at the lower level of the efference range because there's quite a lot of people with high levels. And if you look at just the low people, it can actually make a difference. And this is then looking at resistance. And for the resistance one, these again were significant. And you can see that these are now highly predictive of resistance, the EAMD, the pharmacy refill, and the pharmacy gaps. And these were not predictive of resistance. So again, I don't know if we've actually answered the question which adherence measures do predict things the best. This is looking at so I can tell if they're significantly different because I looked at the confidence intervals of each. So this is looking for virological failure and resistance. You can see that even though pharmacy refill highly predictive of resistance here, the confidence intervals are very wide, whereas the EMD, the electronic device confidence intervals are very narrow. But when you look, that's for resistance. But when you look at failure, basically they looked much the same. So, just to discuss, and I'm nearly finished, the cohort was typical of most other ART cohorts in South Africa. I think it's important in terms of generalizability. You can say that you can maybe give your information to something else. Median adherence electronically was lower than that seen with all the other measures. 80% were still in care with us at a year, and 85% of those had viral load of less than 40 at week 48, which means that overall, so I told you that 85% were suppressed, but those were 85% of the people who had a viral load. So this is not a missing equals failure analysis because I needed the viral loads to do this analysis. So this is only the people that remained in care. So if you actually look at the people that remained, people who suppressed of the total that started, it's actually only 67%. So in the study that presents the randomized study, there's a missing equals failure. This is a sub-study, does not have the missing equals failure because I needed it's a nice comparison of the adherence measures, but it tells you less about the whole cohort. So self-report, as we collected, it was not very good. clinic-based pill counts and mid-dose efferents levels did have some predictive value, but not very much. And the WISE pill and the pharmacy refill measures were the best, but then now you've got to discuss which one would you use. The WISE pill gives real-time data, was better at week 48 than week 16. It is, however, more expensive to do, but you could intervene based on WISE pill because you're getting the information as it comes along, and there's been some data from Jessica Haberer's group in Uganda, which basically shows that you can intervene. They actually send people out to people's homes based on certain criteria of people not opening their WISE-pill device after so many days, and it means you can intervene prior to there being an issue with virological outcomes, which is quite nice, but quite labour-intensive. Pharmacy refill data was very valuable at week 16, which was interesting. We actually have a system already in place, but it's always going to be retrospective because you're never going to know about what they're doing now. You're only going to know they haven't come to collect their medication kind of when you look at the next time. So there's always going to be a delay with pharmacy refill data. You'd have to have somebody really watching, saying someone's due today, why haven't they come, and things like that. Both, however, at the moment are separate from the clinic. So even though we have pharmacy refill data at Guguletu, it's collected in a completely separate system called JAK, and it's at the pharmacy. It's not into the folders, it's not, so there'd have to be some way of integrating it, because the clinic basically has tablet counts and self-report. The pharmacy system is somewhere else in the clinic. Patients go there to queue, it's in a different place, so it's not available or accessible. It could be available and accessible, but it would require some operational planning and input to get that pharmacy data in. And that's it, basically. And I'll just say thank you to everybody who helped. It was a big team, and my funders for that. Good.